Hello again, guys. This will serve as, I believe, the second part, I want to say, of chapter 7. It is growth and development of the newborn. Sorry that it was in two separate segments, but when we had the trouble with uploading the files and people having trouble with the audio, then I went ahead and separated chapter 7 because it was a little long, and it took a little while to upload to Blackboard. So, again, I hope that this helps by uploading it as a video to YouTube so that you guys can listen to it on your phones or your iPads or your tablets or your other media devices on the go, and you can bring this up anywhere. And if there's any problems, please let me know. But this will serve as the continuance of chapter 7, which is growth and development of the newborn. So, with that said, here we go. Here we will continue to talk about chapter 7, the growth and development of the newborn, and we will continue on talking about the essentials in development. Okay, let's talk briefly about health promotion and maintenance. Of course, after birth, as I stated in the previous slide, the infants will receive ophthalmic ointment which is erythromycin. This is usually for gonorrhea and chlamydia, even if the parents do not have it or they say they don't have it and they won't get tested. We usually give it to all infants regardless of their birth, regardless of if it's a vaginal birth or a C-section, they all get it. Newborns also receive the vitamin K shot within 1 hour of birth to prevent hemorrhagic disease. Now, some parents will refuse this vaccine. This shot, and it may be due to religious values, beliefs, and things of that nature. If they do, we want to make sure that we educate them on why it's being given. And if they still refuse, we do not force the issue, but they have to sign a waiver or a right to refusal that they know all the risks and benefits and that they still refuse to have it done. Prior to discharge, most if not all newborns will undergo a screening to rule out diseases and disorders such as sickle cell, PKU, and hypothyroidism. And this is usually done with a heel stick. Again, it's usually done right before they go home. Now, most facilities recommend that the infant has been at least 24 hours of age and that they have good feedings before they do the exam. Some parents refuse this also. If they do refuse to have it done, they are to sign that they are refusing to have it done and that they know the risk and the benefits and that they understand that they are signing that they're going to refuse this exam or this test, because what can happen is if we as healthcare providers or even administrators do not get them to sign, and then their infant comes up with this rare disease that we could have found out by doing the PKU, then what happens? They want to come back and they want to sue. Can't happen if they sign. So make sure that is where documentation comes into play. Make sure everything is documented, especially when it comes to an infant, because things happen on down the line 10 years later, and then they want to come back and say, oh, it all happened when he was at that hospital as an infant. No, it didn't. So you want to make sure you're covering everything. Document. Immunizations are also Another thing that you really want to document, and usually the only immunization they get in the hospital before they go is the hepatitis B vaccine. If the parents refuse, they refuse. We make sure they sign the right to refusal, and we document that they refuse, that they have the information sheet on it. And some parents just refuse because they want the infant to have all the vaccines at the pediatrician's office. Usually your infant will go for a well trial visit within 24 to 48 hours after they're discharged. So you want to make sure that they know that they're signing that they're not going to get it. And you can ask if they're going to get it at the pediatrician's office. But again, it may be a religious issue that is allowing them to refuse. So we don't want to force anything down anyone's throats, but we want to make sure we're covering ourselves and the hospital facility, and we're documenting. You want to note that screenings are important and requirements will differ from state to state. If the newborn has a hearing problem, it should be detected by 3 months, and intervention should be done no later than 6 months of age. They usually will do a newborn hearing test before the infant leaves. If the hearing test is passed, then it is usually documented in the newborn's record. If it is not passed, if the infant fails one or both ears after 2 times, they are referred to an audiologist, and the pediatrician is made aware of that so that they can share that with the parents and make the necessary referrals. We would like to get that taken care of earlier than later in life because, of course, like we talked about, all of the developmental milestones that the child needs to meet may be delayed if they can't hear. Same thing if they cannot see. So, the earlier we detect these things, the better. Alright, let's look at the anticipatory guidance of a newborn. First, we will start with nutrition. Of course, recommends breastfeeding for about 6 to 12 months. If you can breastfeed for longer, of course, that's the goal. A lot of the hospitals now and other facilities are trying to gain baby-friendly designation. And what this means is that the hospital is really promoting breastfeeding, and they're limiting formula and any formula-based feedings, anything like that. They really, really want to promote breastfeeding and education about breastfeeding. So, you want to educate your patients about breastfeeding, but you don't want to be overbearing and make them breastfeed. That is not the goal. If they are interested, of course, you may have to work with them because, like I said, they've never picked up a book or even Googled anything in regards to breastfeeding or taking care of a baby. So they know nothing when they get to you. So you want to be patient and help them latch the baby and teach them techniques so that they will not give up. And you want to educate them about it not being easy. The baby has to learn, and so do they. So once they learn, then it gets easier for both them and the baby. You want to let them know that the baby knows when they're frustrated and upset. So then, of course, in turn, the baby gets frustrated and upset. So you want to educate them about that. You want to let them know that their breast milk has many advantages over formula. There's no mixing. It's always the correct temperature. At least we hope so. If the human body is normally 98.6 degrees or a little higher or lower, it's always warm. There's no sterilization because it's sterile already. It's in your body. It's easily digested and absorbed. It contains antibodies and immunoglobulins, and it is, of course, cost effective. It's free. You produce it for free. Well, if you're a woman. If you're a man and you produce milk, and I don't think that's okay. So to the men in the class, that's not okay if you produce milk. If so, we're going to have to sell you to somebody, science or something like that. But you want to educate the mothers that their breast milk is like liquid gold, is what we call it. But like I said, don't shove it down their throats. If they do choose to formula feed, you want to educate them on the importance of how to properly mix, especially if they're going to be getting canned formula from the store. I believe, I haven't bought any formula in quite some time, that the canned formula is much cheaper than the already made formula. So of course they will probably resort to that, and if they're on WIC, I do believe they give them canned formula as well. So they want to be educated on how to mix the formula. If it is undermixed, you want to teach them that this can cause dehydration. If the kid has dehydration, or you see them in the emergency room with sunken fontanelles, dry lips, dry palate, this could indicate that the infant is dehydrated. And the formula is usually too concentrated. And if it is overmixed, this can cause water intoxication. That happens when they're diluting the formula in an effort to stretch it. Because I think the last time I bought a can of Good Start for anybody, it was like $15. And I don't think you get that many bottles out of that. So it can get very expensive. So I can see how parents will want to stretch that. So you want to educate them about the effects of doing so. You don't want to kill the infant, so you want to teach about that. Make sure they know that cow's milk is not given until it is okayed by their healthcare provider, not when they say it's okay. Soy can be given if the infant is allergic to lactose, and it's kind of hard to tell if the infant's allergic. They may be kind of spitty and they vomit or have diarrhea afterwards, and they just don't tolerate the formula. Most hospitals and facilities have soy-based formulas. They have gentle formulas for those that are gassy and things of that nature. So you want to educate them on the differences. And some parents may just tell you they want a soy-based formula because they're lactose intolerant and their other two kids are lactose intolerant. So if they tell you that, then by all means, you can give them a soy formula if your facility has it. Breastfeeding, you want to make sure they're doing it often if they are going to breastfeed, but please don't force it down their throats. Make sure you let them know about feeding times. Feeding times are crucial. It is crucial to develop a schedule. We usually tell them 2 to 3 hours for breastfeeding and 3 to 4 hours for bottle feeding. Well, that may not work when they get home, and especially if the mom is going to return to work soon. We tell them to create a schedule that works for them in the home. But while they're in the hospital those first 2 or 3 days, we ask of them to go by the schedule that we give them, which is 2 to 3 hours for breastfeeding, 3 to 4 hours, every 3 to 4 hours for bottle feeding. Once they get home, if the infant is sleeping, then of course, if the infant is eating, I would say, for an example, if the infant is eating 50 cc's or 50 mLs of formula, and they sleep for 5 or 6 hours, it's fine. Unless the infant is a monster and they're like 10 or 11 pound babies, then they may need to wake up and eat a little more, especially for your gestational diabetic moms that have these huge babies that are like sumo wrestlers, okay? They're like 12 pounds, 13 pounds. Your islanders, some of your islanders have big babies. Your Pacific islanders, they have big babies. So you want to educate them. There has to be some kind of happy medium. Of course, if they're feeding their babies 70 cc's and the baby's 12 pounds, I get it. Versus your baby's 5 pounds and you're feeding them 70 cc's. That's probably not okay. The baby's going to have all kind of gastric reflux and aggravation and upset stomach and things of that nature. So you have to kind of gauge where the baby is and assess the baby, and then educate your parents regarding feeding times. You want to also educate them if they are formula feeding. Please, please, please do not prop the bottles in the car seat or the cribs. This can decrease the attachment process, which is very crucial in the infant stages, and it can also cause dental caries for these infants. So you don't want to start messing up their teeth before they even get them. If they are breastfeeding, you want to teach the parents how to release suction by placing a finger in the side of the mouth and between the jaws, because if not, what's going to happen? They're going to have very, 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 very sore nipples and blisters and cracked skin, and it is no fun. And then they're going to be engorged if they can't feed the baby. So once they get home, they may practice feeding on demand, which is basically when the baby's hungry. If you have a baby that has issues, then of course we may put you on a schedule or tell you to keep some sort of schedule. Of course, you want to let them know that formula digests slower, and therefore infants may only want to eat every 3 to 4 hours, whereas the breastfeeding, it's like every 1.5 to 3 hours, because like I said earlier, it metabolizes very, very fast. You want to note that their stools should be light yellow, and they should have soft yellow stools when they are breastfeeding. When looking at thermoregulation, you want to note that this is controlled, of course, by the hypothalamus. They are usually unable to maintain heat without help. They can become very cold very easily, so this is why we tell moms to either keep them skin to skin or have them wrapped in a blanket. But remember what I said earlier, do not overheat them, so they shouldn't be in a fleece blanket, a onesie, a fleece pajama set, socks, a hat, mittens. All of that is overkill. Do not overheat the baby, but don't allow the baby to have on no clothes and no blanket and shiver in the room. That's not okay either. As far as sleep, you want to know that the term newborns have light and deep sleep periods. During deep sleep, hardly any movements are made, no eye movements, except occasional startles. During light sleep, the newborn has eye movements. During 10-second intervals, stretching and minor twitching occurs. They will usually sleep between 16 and 19 hours a day, with intervals lasting 45 to 50 minutes at a time. Often the infant clock does not correspond with families, so this may cause undue stress. You want to educate your parents that this is normal. You want to, of course, please, please, please stress how important it is to put the babies or the infants on their back to sleep. This prevents SIDS. Please tell them not to have all this crazy stuff in the crib, like stuffed animals, pillows, all these fleece blankets that the infant can roll over on and suffocate themselves, or pull it over their face and get tangled up in it. None of that is good for the infant. So there should not be anything excessive in the crib. You also want to teach them to avoid water beds, comforters, extra soft bedding, like I said, and pillows. And I know water beds sound kind of odd, but we've had some parents sleeping with the infant in the water bed, and what happens is they actually end up rolling over onto the infant and not knowing, because what happens in a waterbed? Everything's moving all the time. So they do not know that they have rolled over onto the infant until the next morning. And by then, of course, it is too late. You want to make sure that I'm going to go backwards a little bit. When you are feeding the baby, you want to make sure you're teaching the parents or guardians or even the babysitters or whoever's going to be caring for the child how to clear the child's airway. I can't stress that enough, how important that is. Clearing the child's airway. They need to know how to at least suction the nose and the mouth. They need to place the newborn on their side with the head slightly below the body, and they need to use the bulb syringe. This is the importance of having a bulb syringe. We usually give parents a new clean one when they leave the hospital. Some parents go out and buy one. Of course, we as nurses will be the worst patients ever because we come in with all of our stuff and we don't want any unclean stuff and germs and all of that stuff. So you just want to do a lot of education when it comes to things that we would think are common sense are not so much those that don't have a healthcare background. When looking at instructing on diaper care, you want to instruct them to wipe from front to back for females. This prevents the feces from contaminating the vagina. Keeping the diaper clean and dry is the best prevention against diaper rash. You want to educate these parents that love to put paste and diaper rash cream and all of this stuff on baby, and the baby has no rash. We need to instruct them that keeping the baby clean and dry is what prevents the rash, not overly putting these creams before something even happens. We're not putting cream prophylactically on the baby, okay? So educate them on that. If the baby does develop a diaper rash, it can range anywhere from mild to severe. You want to contact the health provider if the rash does not go away within 48 to 72 hours or it gets worse, such as open sores and blisters. This would be the time to worry. But you want to educate these parents that if they leave the infant in a wet diaper all night long or in a soiled diaper all night long or even, 6 hours, that's excessive. We usually tell the parents to check with each feeding if your baby has peed or pooped and go ahead and change the diaper. And the baby will actually, really, it's common sense, but some people lack that. So tell them to keep the baby clean and dry, and that will usually help in preventing diaper rash. As far as safety goes, you want to keep an eye on the infant. They're not immobile. They can roll off the couch. I mean, we've heard so many crazy stories. They left the baby on the couch because they thought they couldn't move. What are you talking about? Baby may not can roll over as a newborn, but they can move and squirm. And if you put them in the middle of the couch, what's gonna happen? A sudden noise may startle them, and they jerk, and there they go onto the floor. So common sense, people, but we still have to teach them these types of things. You want to make sure they're not leaving them alone when they're bathing them, not even in the sink. They can drown in like 1 foot of water. Hello, they can't swim. So, you want to let them know about that too. You want to make sure they're not placing the infants in the car seat incorrectly in the front of the car. Make sure they have the right size. Make sure they place them in the back of the car and, if possible, in the middle. If there is no middle seat, then they can go on either side, but it should be facing the rear. It should not be facing forward. You want to also teach them that secondhand smoke can kill. Even these little vaporized electronic cigarettes, we still have yet to determine what's in them. They too can be harmful, so we recommend not smoking around the baby at all. We want to let them know that this can cause recurrent otitis media and respiratory infections. Also, you want to keep an eye on the baby's cord stump. Although it takes 1 to 3 weeks to go away or to fall off, you want to make sure the parents are keeping an eye on it and educate them on when it is pertinent to call the doctor regarding this problem. If they notice that there's redness at the base of the umbilical cord, or if it starts to bleed, or if it starts to have a foul odor, that they need to call the physician or their pediatrician and let them know there may be some type of infection brewing. Your role as the nurse will serve as a caregiver, an advocate for the infant because they can't speak up for themselves, as well as an educator. Dealing with pediatric patients, whether it be newborn, school age, adolescents, toddlers, anything of that nature, the parents and guardians seem to need a lot of education. So you will spend a majority of your time doing education. You also want to make sure you're letting the parents know when it is pertinent to call the physician. Because if this is a new infant for the parents, they are going to want to call the physician for every little thing, and they don't need to. The umbilical cord problem, I just spoke on that. Another issue is if the baby is inconsolable and crying, they may have colic, and before it is even diagnosed, the nurse may intervene and ask, more questions as to what symptoms they're having, because there are definitions to colic before, that can be diagnosed. So there are certain things that the parents need to know, and usually this is printed on their discharge instructions on when to call the doctor, although I really don't think most of them read it. So verbal education is a little more pertinent, although they probably don't remember half of it. You can make sure if the baby has a temperature, they should call not for a temperature of 99. That is not a temperature to us healthcare providers. The discharge instructions usually say 100.4. And that is if they have not gotten any vaccinations. Because if they get vaccinations, it's normal to have a fever. So they need to know these little things, and the little loopholes that they don't have to call the doctor if, little Tommy or little Veronica just got 2 or 3 vaccines and now she's feeling icky and she has cold-like symptoms and she has a fever. These are all normal things, which should go away in a couple of days. So they need to know these types of things when it comes to safety promotion, health promotion, injury prevention, and emergency situations for the infant. And I know I keep saying infant, but I am referring to the newborn just so that you're not confused on if I'm talking about infants, which is in chapter 8. I consider them all infants, but I am referring to the newborn, which is, birth to 28 days. So I don't want you guys to be confused as to, is she really talking about the right thing, or am I on the right chapter? I'm in the right chapter. So we're on the newborn, okay? Last things in this chapter that we will briefly speak on are the differences in babies and the high-risk newborn. So I do want you guys to just read over the differences and note the differences for LGA, SGA, and AGA. Of course, your LGA would be your large baby, your SGA would be your small babies, and your AGA are your average gestational age babies. A couple of points I want to make on the sizes. Your large babies or your LGAs, some of those are due to your gestational diabetics. That's usually what we see them with, whereas your SGA babies may be from intrauterine growth retardation, or even your moms that were smokers, or trying to think of another. They had some type of developmental crisis in utero, or they had placental insufficiency, or oligo. They didn't have enough fluid within mommy, so caused them to be small. Or mom could have been bulimic, or anorexic, and she wasn't getting enough nutrition. As for your preterm babies, depending on the facility you're with, it's usually a baby that's less than 37 weeks. And again, depending on the facility, the orders may be a little different on how we care for those infants. So I don't want to give you specifics, but it may range from doing vitals every 2 hours to providing oxygen for however long, to doing blood gases, to monitoring the heart via telemetry, and things of that nature. It just depends on how the baby comes out, their APGARs, how they're looking after that initial assessment. Your post-term babies, those are the babies that stay in the oven for a little too long and they cook and they just don't want to come out. They may come out a little dry and wrinkly because the fluid has started to diminish. These are your babies that are over 40 weeks. They may be scheduled for a C-section if they cannot come out on their own for vaginal delivery. So we want to keep an eye on those infants as well. Like, why did you want to stay in there? What's going on? So they may do a more thorough assessment on them as well. Now, care for these high-risk newborns. Just a couple of points that I want to make when caring for a high-risk newborn. Of course, you want to ensure that you have proper staff if the mom has a high-risk pregnancy. High-risk pregnancy will include your pregnancy-induced hypertension, your gestational diabetics, your moms that have had all kinds of drug or alcohol abuse, if they are severe preeclamptic, and things of that nature. So you want to make sure you have the adequate staff there. And usually it's the NICU staff, a neonatologist on call there, so that things can happen quickly once the baby comes out if the baby's not doing well. The infant may need to go to NICU if homeostasis cannot be maintained, and all high-risk pregnancies must be done in the hospital. I make that statement because a lot of patients are now seeing nurse practitioners and midwives, and note that the midwives cannot deliver in the birthing centers if mom is high risk. They have to be in the hospital because of the amount of resources that are available in the hospital versus a birthing center. Alrighty then, folks, that looks as though we have completed chapter 7, which goes over the growth and development of the newborn. And again, I do want to emphasize that I may have referred to some of the things that I was saying within this chapter as the infant. I do not want you to be confused. I was referring to the newborn. I call all of them infants. After working with them for so long, it's like they're all an infant to me. So I was referring to the newborn, which is basically what we see in the hospitals, unless you're doing pediatric nursing, where you will see the actual infant who is considered after 28 days, a month to 1 year. You will see that as a pediatric nurse, not so much as mom baby, or well, you might see it as a NICU nurse. Of course, as a pediatric ICU nurse, you will. So terms may get intertwined there, but of course, during this lecture, I may have said infant quite a few times because that's what I refer to all our newborns as. But I was referring to the newborn, so I don't want you guys to be confused on any of the information that was relayed. So take this time to review the information. Any questions that you may have, please let me know. And also try doing your questions at the end of the chapter. That should be a good review for you, as well as the questions in your workbooks. If you purchased a workbook with your textbook, those are also helpful. look forward to working with you on Chapter 8, which will be the growth and development of the infant. Okay, guys, so that was the end of Chapter 7, and you should be able to pull up now. Chapter 8 and 9 should be up shortly. So if you have any issues with any of the videos, 7, 8, or 9, please let me know. I will not be on campus until next Wednesday afternoon. So if you do have any issues, please feel free to text or call me, and we will try to get those resolved.